it is filled with 30 to 50 ml fluid and not interfering with dynamics of the heart, right? And when the inspiration occur, what happens? First I will talk about when inspiration occur, what happens. When inspiration occur, you know, lungs are shrinking or expanding. Now, let's suppose this patient is undergoing inspiratory process. So naturally chest wall is expanding, diaphragm is going down, and intrathoracic pressure is becoming more negative. Intrathoracic pressure is becoming more negative, so that the air can be sucked in. The purpose of when diaphragm goes down and chest wall expand anteroposteriorly and side to side, laterally, what happens? Intrathoracic pressure becomes negative. When there is intrathoracic pressure become more negative, it sucks the air in. It sucks the air in. That is what we call inspiration. That is what we call inspiration. Is that right? But with that, it also sucks the systemic venous blood. Chest cavity, the venous return from here and venous return coming from other superior vena cava and inferior vena cava, it also becomes faster. Again, listen. During inspiration, right, chest is expanding, thoracic cavity is expanding, pressure, intrathoracic pressure become negative. As air is pulled in, enlarging cavity and increased more negative intrathoracic pressure also pull the venous blood from superior vena cava and also venous blood from inferior vena cava. So venous return to the right heart during inspiration is less or more? More. Is that clear to everyone? So venous return to the right heart during inspiration becomes more. So when there is more blood coming here, so that will lead to what? Enlargement of right ventricle. It is slightly overfilled. When right ventricle is slightly overfilled, it will expand in all dimensions. Right ventricle will expand in all directions during inspiration. It will expand in these directions. Free wall will expand, as well as higher amount of blood will not only push these walls, it will also push the septum. So during inspiration, not only this extra amount of fluid which is accumulating here, not only free wall move outward, this free wall, this will move outward, this septum, interventricular septum is pushed towards the left. So but this push is very slight. Suppose this is the septum. During inspiration, it becomes slightly, not very severely, slightly deflected to the left. So during inspiration, due to right-sided overfilling, there is slight deflection to the left side. So filling to left side will become slightly less. This is one reason why during inspiration, left-sided heart is slightly underfilled. There is another reason why left side is underfilled during inspiration. During inspiration, lungs are expanding. During inspiration, lungs are expanding. When lungs are expanding, the pulmonary circulation is compliant, stretchable. So when lungs are expanding, not only air pockets expand, but also vasculature or pulmonary vasculature also expand. So capacity of pulmonary vasculature during inspiration become more or less? More. So it becomes more capacity. So it try to hold the blood during inspiration. So blood from the lungs going to the left side of heart will be less or more? Yes. Less. You are understanding? So during inspiration, two things happen. One thing is there is negative intrathoracic pressure, pull more blood to the right side of the heart, and right ventricle overfilling slightly push the septum to the left, and that make the left slightly underfilled. Second reason is that left side of the heart is receiving the blood coming from pulmonary circulation, and as lungs are expanding, pulmonary circulation is compliant, pulmonary circulation expand, and venous return to the left heart become less. Of course, when venous return to left heart is less and also septum is slightly deflected there, so this will be overfilled left side or underfilled? Underfilled. Yes. So during inspiration, right overfilled and left underfilled. But still this can expand. There is very slight movement of septum, because expansion can occur in this direction and also in this direction. Now, but in normal person, right now when you go inspiration, left side is underfilled. Of course, end diastolic volume is less. What will happen? End diastolic pressure is less. Myocardial stretch on the left ventricle is less. Contractility is less. Stroke volume is less. Cardiac output is less. And systolic blood pressure slightly drop. This is physiological drop. This is physiological drop. In normal person with normal respiratory, right, healthy person, during every inspiration, left ventricle becomes slightly underfilled, and due to that reason, cardiac output becomes slightly less and systolic blood pressure becomes slightly down during, yes, during inspiration, and reverse will occur during expiration. So we can say, let's suppose this is inspiration, right? Okay, let's start the cycle with inspiration, and let's start with expiration because it will become easier to explain. In expiration, opposite occur. What will happen? During expiration, chest cavity is becoming smaller, intrathoracic pressure is less negative, right? What will happen? That cable blood will be pulled less efficiently, so venous return during expiration, venous return to right side is less, and because lungs are being squeezed during expiration, venous return to left side is more, and cardiac output during expiration becomes more, and systolic blood pressure goes up. Now, if you very carefully check the blood pressure during, let's suppose this is 80 and this is 120, systolic blood pressure during expiration is, suppose if it is 80, 120, during inspiration it will fall, right? During inspiration it will fall, and in expiration again it will go up, and then again inspiration it will fall, and then expiration it will go up, and then in inspiration it will fall. Now, this fall, this inspiratory fall during inspiration, this inspiratory fall of systolic blood pressure, right? Inspiratory fall of systolic blood pressure, if it is, this fall is less than 10 millimeter of mercury, it is normal. For example, blood pressure during expiration is 120 by 80, and blood pressure during inspiration is, suppose, 114 by 80. How much is the difference? 6. So this is normal. So normal inspiratory drop in systolic blood pressure should not be more than 10 millimeter of mercury. Is that right? Pardon, can you say it more loudly?
Any difference in systolic blood pressure during inspiration?
I will not talk about that later, but if you really want to know what is the difference in diastolic, the reason being during inspiration, sympathetic slightly overflow occur, a little tachycardia is there, and arterioles constrict. So diastolic may go slightly change. But right now in explaining of pulses paradoxes, I will focus on systolic blood pressure. So what we have learned up to now, during expiration systolic blood pressure goes up, and during inspiration systolic blood pressure come down in normal person, and this difference should be less than 10 millimeter of mercury, right? Then it is normal. Now what is pulses paradoxes? Actually listen, what is pulses paradoxes? Pulses paradoxes is a condition in which inspiratory drop in systolic blood pressure is more than 10 millimeter of mercury. Again I will repeat. What is pulses paradoxes or paradoxical pulse? Paradoxical pulse is a situation in which during inspiration systolic blood pressure drop or decrease more than 10 millimeter of mercury. Then we say there is pulses paradoxes. Even though, or another way to mention it is that pulses paradoxes is a condition in which normal physiological drop in systolic blood pressure is exaggerated. Normal physiological drop in systolic blood pressure is exaggerated beyond the normal limit. Am I clear? Now, so Example, classical example of this can be, let's suppose this is another person in which systolic blood pressure is going like this, normal tracing is going like this, but here it become like this. Here it was 120 by 80 during expiration. And if there is pulses paradoxes, I will explain why pulses paradoxes develop just in 2 minutes. But first listen, what is pulses paradoxes? Pulses paradoxes condition that during inspiration the drop which is supposed to be less than 10 millimeter, it is too much a drop. Rather than here it was normal person, I'm just giving example, it was 120 and it was 114 or 110, then it is normal. But if this is 120 and this is, let's suppose it is 100 systolic blood pressure, right? In this case, we will say the systolic blood pressure, total blood pressure during the, what is this? Expiration, it is 120 by 80, and maybe during inspiration, it has become 100 by 80. Pulse volume has become less. Sometimes it becomes so less that pulse is very weak. Peripheral pulses become very weak, or rarely they may be absent. You are understanding? During inspiration. But pulse should appear during expiration. If it is absent all the time, it's some other story. Right? Am I clear? So, now what we have learned up to now, only we have learned one thing. What is pulses paradoxes? Pulses paradoxes is a condition in which normal physiological inspiratory drop in systolic blood pressure is exaggerated and it is more than 10 millimeter of mercury. Am I clear? Now, pulses paradoxes is one of the important clue towards the what? Cardiac tamponade. Even when some patient comes with acute pericarditis and effusion, even if cardiac tamponade is not there, you repeatedly check the patient's pulses, check the blood pressure and JVP and heart sounds. And if JVP start rising and pulses paradoxes appear with hypotension, you have to think of cardiac tamponade. Am I clear? Now, why the pulses paradoxes appear in this funny situation we are discussing? What is that? Yes, my friends, cardiac tamponade. Yes. I was thinking you are having silencer in your mouth. Okay. Now, we need to explain why pulses paradoxes is present in tamponade. Let's see what is this our sad heart. Okay, this is our very sad heart. This is a very simple diagram. Now this is, of course, what is this? This is cardiac tamponade, pericardial effusion under high pressure, right? It's more than the filling pressure, so it is compressing the ventricles. Here you need to remember, low pressure chambers are compressed more easily. For example, atria are compressed easily, right ventricle is compressed easily, left ventricle is difficult to compress because it is a very thick wall. You understand? So usually compression or collapse during the diastole, this collapse of the free wall or compression is seen in the right atrium and right ventricle. Now listen carefully. What really happens? During inspiration, in a patient with cardiac, what is this? Cardiac tamponade. In cardiac tamponade, because there is pressure, first of all, when blood will be filling into ventricles, can ventricles significantly expand this? No, because in cardiac tamponade, cardiac chambers are encased or entrapped in a fixed area where fluid filled cavity is not expandable. You are understanding? If it was stretchable, there will be no tamponade actually. So tamponade only develop when this is surrounded by such a fluid filled cavity which has enough pressure, does not allow it to expand. Now the real competition will develop. Because there's a little space in which right ventricle has to fill as well as left ventricle. So both ventricle will try to fill in the same little space. During inspiration, what happens? During inspiration, I told you during inspiration there is increased venous return to right side and less venous return to the left side. But usually in a normal person, not patient with cardiac tamponade, normal person, during inspiration when there is overfilling of the right side, right chamber will expand in all directions. Will expand in all directions. But in patient with cardiac tamponade, when there is increased venous return to the right heart, can this free wall expand here?
No.
So there will be too much pressure on what is this wall? Septum. So there will be too much deflection of interventricular septum towards left side. You understanding? There is exaggerated motion of interventricular septum towards the left side during inspiration. I told you in normal person also very little deflection of septum occur to the left. But why in normal person there is little deflection? Because heart is, right chamber is expanding in all dimensions. But in case of cardiac tamponade, cardiac chambers are encased in a small and fixed space surrounded by a fluid filled cavity which is not expandable. And both chambers have to compete for the ventricular filling. And during inspiration, our physiology is favoring the right side. Because during inspiration, and especially inspiration becomes more deep due to respiratory distress and intrathoracic pressure become more negative. So there will be more traction on the systemic blood for filling during inspiration. So what happens in patient with cardiac tamponade, during inspiration when there is right side going to be overfilled, it cannot expand into all dimension. So there is exaggerated push of what? Interventricular septum towards the left side. So left side, which during inspiration normally underfilled, now it becomes extremely underfilled. If it is pushed towards that side, can it fill well? No. So normally left ventricular filling during inspiration becomes slightly less, and now in tamponade, due to strong abnormal leftward deflection of what? Septum, and left ventricle become moderately or extremely underfilled, and when it is underfilled, remaining story you know, end-diastolic volume less, stretch less, contraction less, stroke volume drop significantly, and if stroke volume drop too much, cardiac output during inspiration drop too much, and systolic blood pressure drop too much, and that is what produces pulses paradoxes. So what, am I clear now? So let's see again. This is suppose expiration, right? Inspiration, normal person. Expiration, inspiration, you are understanding? Now if tamponade start developing, expiration, little hypotension is there. Expiration with, during inspiration, expiration, during inspiration. Now you see this drop, here drop was less than 10 and here drop has become more than 10. That is pulses paradoxes. Now how do you clinically assess in the patient, because there's no fun in learning this theory if you cannot pick up into the patient. Am I right, Dr. Iftihar? You need to pick it up. So how do you pick it up? It's very simple. As you know, I will not go into fine detail of how to do the blood pressure measurement. I understand you know that very well. I will just tell you how to pick the pulses paradoxes. What you really do, that you put properly, what is this? Handcuff? Okay, sphygmomanometer cuff, okay. So sphygmomanometric cuff, you put it here and inflate it more than what? Significantly more than the systolic blood pressure. Now, you start dropping for example, you have inflated up to 140. You start dropping it slowly. Okay? You start dropping the blood pressure. Okay, I want to show. This is pulses paradoxes. Now how you will catch it? You start the sphygmomanometric pressure slowly until during expiration right? If you reach up to 120 and systolic blood pressure is about 120, at the pressure of 120, vessel will allow some blood to move. Blood will move through this vessel as soon as cuff pressure becomes slightly less than the systolic. You are getting it? Now this will, first Krotokoff sound will appear. This sound will appear during what time? Expiration. Let's suppose this is 120. For our understanding, we call it, the sound is appearing at 120, we call this sound K1. Krotokoff 1 start appearing at pressure of 120. After that, you start bringing the blood pressure down very, very slowly. Sorry, not blood pressure, cuff pressure. When you are bringing it, deflating it very slowly, right, during inspiration, systolic pressure was, let's suppose, imagine it was 100, and you bring the pressure of 110. During expiration, when pressure has brought from here the K1 came. This K1 appear only during expiration, but it will become here at this point. Will the blood pass through the artery? No. Will you hear any sound? No. So during the throughout what? Yes? Inspiration. Throughout the inspiration, you will not hear the Krotokoff sound. But as soon as you go to expiration, again sounds will appear. You are understanding? So what happened? That we come here. That first sound was, this was expiration. This was inspiration. What was this? Expiration. This is inspiration. Same here, expiration, inspiration. Expiration, inspiration, expiration, inspiration. Now let me help you to understand. Cuff pressure was here. When you brought it here, these sounds will start appearing. Is that right? When cuff pressure and systolic pressure are almost equal, Krotokoff sound appear. But when inspiration come, because inspiratory drop is there, if you are maintaining almost above it, cuff pressure, sounds will disappear. Now you keep on bringing the sounds, you keep on bringing the cuff pressure very gradually down. Again, when expiration come, again Krotokoff sound will start appearing. Again, when inspiration come, what will happen? They will disappear. Then again in next expiration, you have to do it very with patience. During next expiration it will appear, but now gradually you have come significantly down. Let's suppose you have come to 100. When your pressure is equal to lower end, what will happen? That during expiration sound was appearing, but as soon as your cuff pressure is somewhere here, suppose it is 100, then sounds will appear not only during expiration, but it will start appearing during inspiration also. So this is when sounds are heard throughout the respiratory cycle, during expiration as well as during inspiration, we can call it K2. This pressure is K2. It is not K2. Okay? So K1 was, let's suppose 120, and K2 was, let's suppose, we are just supposing, K1 was 120 and K2 was what? 112. Is there pulses paradoxes? No. Very good. Right? Now if it is 120 and this is 112, the difference is 8. You need to take classes in mathematics. Right? So then what happens? That we say there is no pulses paradoxes. But let's suppose that patient sound, Krotokoff sound which appear only during expiration, K1 which only appear during expiration is at 120, but sounds appear in expiration and inspiration both, right, at the pressure of, let's suppose 100, then that systolic drop during the inspiration is more than 10 millimeter of mercury. This should be called pulses paradoxes. So this is how you measure the pulses paradoxes, and of course you will keep on taking the blood pressure down. Eventually all sounds disappear and you say there is diastolic blood pressure. Is that right? So this is how you measure the what? Pulses paradoxes. Remember one thing, when you are measuring the pulses paradoxes, don't ask the patient to take a very deep breathing, because that will produce false positive result. Even a normal person like you, if you take very, very deep and hard breathing, right, you can produce some degree of pulses paradoxes. So some doctors become super intelligent. They ask the patient, I'm checking for pulses paradoxes, you take a deep breath. Even if it is not there, it will appear. You are understanding? So don't ask the patient to do inspiration deep, specifically deep inspiration and hold that, because that may produce a false positive result. Now, actually pulses paradoxes is not specific for cardiac tamponade. It can be positive in some other conditions also. For example, pulses paradoxes may be present in chronic obstructive airway diseases like asthma. If you have asthma and you are breathing very strong, you can say that when chronic obstructive airway disease or even sometimes acute obstructive airway disease is there, and to take the air in, you have to generate very negative pressure in the chest. You take very strong and hard breathing with difficulty. Then what happens? You pull the air with a lot of power in. You also pull the, what is this? Venous blood very rapidly, and there is exaggerated motion of the ventricular septum producing pulses paradoxes. So pulses paradoxes may also be present in airway diseases. Then pulses paradoxes may be present in constrictive pericarditis, but less often. Here I would love to mention that pulses paradoxes is more common in cardiac tamponade and less common in constrictive pericarditis. About 30% patients with constrictive pericarditis may have pulses paradoxes. And Kussmaul sign. Kussmaul sign is that during inspiration, normally during inspiration, jugular venous pressure goes down. But if during inspiration, jugular venous pressure fail to go down or even goes up, this is called Kussmaul sign. Kussmaul sign is present less often in cardiac tamponade, and Kussmaul sign is present more often in constrictive pericarditis. That I will explain in the lecture with constrictive pericarditis. Then some other conditions in which pulses paradoxes is positive. One I told you, of course, cardiac tamponade. Then there is obstructive airway diseases where there is too much negative intrathoracic pressure. Then pulses paradoxes may be also present in pulmonary embolism, because if there is pulmonary embolism, right heart cannot pump into lungs. So right heart will become too much overloaded in pulmonary embolism, and left heart is not receiving the blood. Very less. If there is massive pulmonary embolism and pulmonary artery is significantly blocked, right heart become overloaded and left heart become underloaded. So naturally inspiratory blood pressure will significantly drop, systolic blood pressure. So pulmonary embolism also can produce pulses paradoxes, and severe hypovolemic shock also can produce pulses paradoxes. Now let's have a break and then we'll talk about the management of this condition. Okay, class dismissed.